right. Patient signs and symptoms consistent with hypercortisolism and confirmed hypercortisolism on multiple lab evaluations. So I told you I did the prelim stuff, okay? Denies any steroid use. The patient's plasma ACTH level is very low. So which one of the following is the most likely etiology of a patient's signs and symptoms? Okay, so good, kind of like my little fuzzy tree. This one. So take a moment, look at the answers. Makes sense to you? All right, who says A? Who says B? Who says C? Who says D? Who says E? Okay. Most of you got it, right? Okay, so when I say hypercortisolism, is that, if you think, is that like what Cushing's syndrome or disease looks like, or is it what Addison's looks like? Cushing. Okay, good. So E should come off the list, correct? Make sense? Okay. C should come off the list because I've never talked about tuberculosis ever. Good call. Good job. All right. So the other one could potentially cause this to happen. So if my ACTH level is very low, like non-existent, very low, and I put it on a test tube, very low. So that means my negative feedback system is working. So that's the right answer. Does that make sense how we got there? So what do you also call this? Is it a dependent or independent cause? Independent. Independent means I'm not secreting that. It's a stupid way. I didn't invent the words. I'm just trying to teach you it. So again, that's the independent cause. So ACTH, independent cause of hypercortisolism. So one, the big thing is read the question carefully. So I'm saying I have hypercortisolism. So take Addison's off the list, right? And to understand the lab values are very important as far as how you go about figuring that out. So the only one, because I said the patient denies steroid use. So exogenous glucocorticoid use, that's a big one, right? The patients that admitted taking steroids, boom, have my answer. I don't need to confirm this anymore. But if I deny taking steroids, I know it's not from that source. The only thing that's left is coming from my adrenal gland. Does that make sense for everybody? All right. 30-year-old woman presents with fatigue, anorexia, muscle aches, and hyperpigmentation. Laboratory test is significant for a sodium level of 128, which is low, and potassium level of 5.6, which is elevated. Which of the following is most appropriate to obtain next in the workup of this patient's condition? There's technically two answers you could say, but there's only one on this list. Only one on this list of attempts. So I can't underline anything on the exam, so just pay attention when I'm saying initial, what you do next, stuff like that, and those are very intentional words, okay? All right, who says A? Who says B? Who says C? Who says D? Who did not raise your hand? Picked E, good job. So D. So in addition to a low morning serum cortisol level, you would also have an elevated ACTH to confirm suspicion, right? So again, I didn't write that in the question because it's very long and wordy, but so ACTH co-syntropin stimulation test, remember, that's not the first test you do for the patient, right? The first thing you do to diagnose the patient, you have to have a low morning cortisol level in order to do an ACTH stimulation test. Low ACTH level, that's definitely not the case. Because what do you expect to say? If I say I have hyperpigmentation, what do you think I have a high level of? ACTH. Exactly. Remember, that's what happens up in the pituitary. I'm kicking out my ACTH, trying to get my stupid cortisol to do what it's supposed to do. It's not going to work. But so I kick out my ACTH levels going crazy, but because of that, my melanocyte-stimulating hormone is also being activated, so I get awesome bronze skin. So you wouldn't have that. CT of skin or adrenal glands. For love of Christmas, do not order imaging before you do labs. Always always labs first and imaging after, okay? And so that's doing the right one. But it'd be much more perfect if it said low plasma cortisol and elevated ACT. Does that make sense? Or confuse the crowd, yes. Thank you also to my one awesome person, yay, who used the discussion board, yay. Thank you. Please keep that going. I love it. All right. All right. Wrong one. Sorry. It's not this long an exam. Shut up. A 47-year-old woman with a history of hypertension presents to emergency department with severe headache that begins suddenly 3 hours prior to arrival. She's recurrent frontal headaches for the past month and is currently being treated for migraine. Today she complains of blurred vision, diplopia, nausea, vomiting, confusion. Her vital signs are she's hypertensive, she's tachycardic, less increased respirations, and born temperature. Pulse ox is also born. So neurologic exam reveals a dilated, minimally reactive left pupil, a globe deviated inferiorly, and bitemporal hemianopsia. Lab results reveal only hyponatremia of 129. Normal staining emitted, a CT scan reveals an intracellular mass. Which of the following is the appropriate step in the management of this patient? So sometimes it's better to just read what am I asking you and then read the vignette, because sometimes you don't need the vignette, just so you know. It's good test-taking techniques. I used to be kind of a nerd, not anymore. All right, so who says A? Who says B? Who says C? Who says D? Okay. We never ever talked about medical in my life. So, why is that the right answer? What condition do you think this girl has? Macroadenoma leading to what? Exactly. So hypercortisolism, exactly. So she basically has adrenal crisis. This is presenting a CT scan reveals an intercellular mass. What is that? So that's a pituitary. The only thing that's up there, right? Pituitary. Intercellular mass. So this person is huge risk for pituitary apoplexy. But that's what led to her needing steroids, and she presented a lot like that. So blurred vision, diplopia, nausea, vomiting, confusion. She's hypertensive, tachycardic, not feeling great. So again, I didn't add the pituitary apoplexy slide to this, but this is the process for why you need to give him steroids. Give him steroids. Like I said, I was treated for pituitary apoplexy, if you care about that, and I didn't have that at all because I was the ER protocol. But give immediate corticosteroids. Don't wait. Does that make sense? Or leave the writing. Crickets, good job. All right. All right, 37-year-old patient presents to your clinic for hypertension follow-up. He was on lisinopril 200 milligrams a day, and 1 month ago you increased it to 40 milligrams per day. Please comply with medications, always important. Over the past several visits, he had the following blood pressures. You can read them. They're not amazing. His BNP is below. I can't bold anything for you. Sorry, guys. You gotta, read the low stuff by yourself. So the one that's abnormal looks like a potassium level. Low. Nothing else is abnormal. Even more time to that. Good job. Which of the following would be an important part of workup of his hypertension? Important part of the workup of his hypertension. All right. Who says A? Who says B? Who says C? Who says D? Who says E? Because you didn't raise your hand. Well, those who raise your hand are good. So running activity also is PRA and 24-hour urine aldosterone. So again, for running activity, you give them, you check their aldosterone level and you check where the potassium level again. So again, that's very important. You kind of know why you're doing that, and then you confirm with that. Because what do you think the patient has? Exactly, hyperaldosteronism. Hyperaldosteronism. Does that make sense? So I got there? One thing, it wasn't Cushing's and it wasn't Addison's. We kind of talked about the middle. or towards the end, I'm sorry. Any questions on this stuff? Are you complete zombies right now? Yep. Absolutely. I need to change them to normal ranges because they're off actually, but just trust me, they're normal. So low potassium in somebody he was 37 on meds forever, doing great. Then I bump it up, and is it working or is it not working? Hell no, not working. That looks terrible, right? So even in one medication, that is still crazy ass blood pressures, and often diastolic is even higher than the systolic number, but they're both elevated. But low potassium, which is the reason why we do labs in our patients, that's often the ringer for you to think about, what am I going to do next? What am I going to do next? This is not like, oh, you're good to go. No, then you didn't have endo from me. Not for me. But so this is a way you can do this. So the number one cause, hyperaldosteronism is the number one cause in resistant and refractory hypertensive patients. And it can happen at any time. Anytime. Not like, oh, I'm like, it's genetic. No, it's not like, it just happens. So, underdiagnosed. All right, any other thoughts, questions, worries, issues? All right, so, I don't think we're going to need all of today. If we do, maybe just the ClinCore, because I have a great quick story for you guys. And then I also have ClinCore at the end of that. So if we don't get to ClinCore, honestly, I could probably do the ClinCore if you don't finish it today on Friday or Thursday. I think that's not going to see you guys. Like, I'm supposed to see tomorrow, but I don't think anybody wants to see me at 1500 anyway. Anyway, I get that. So I think we could do that on Thursday and also give you guys the review on Thursday. So do your vote or whatever apps you like. Let me know if that works out for you guys. So you let me know. Cool. All right. Friday, you're stuck with me for 2 hours. The reason why, the Friday is the lab, and the lab is basically a lot like ClinCore, but more patients. And again, it's about how you understand how the patient presents. It's a really good way of kind of looking to see, am I ready for this exam? Do I know what labs are needed? Do I know the signs and symptoms of the case? And there's like basically several of them, longer versions for ClinCore. So please, for the love of Christmas, make it mandatory unless I sign something where I'm going to be gone, okay? Like absence slip or whatever, but otherwise, please be here. I think it's very, very helpful to lead you into that, and thankfully it's, I'm really sad you guys have a test that day, because oh no, I thought we could like have a week setting, but study the crap out of endo, please. MPH, whatever, it's fine. Prevention, okay. The endo's, it's a beast, very lab heavy. That's a long answer to a short question. Cool. All right, sorry. All right, so we'll get through this. MEN, I'll show you exactly what I want you guys to know over MEN. We'll talk about adrenal insulin, and let's see kind of a summary of all the crap that can go wrong in the adrenal gland in the middle. Okay. All right, that's what I'm going to talk about. Yay, you tell me. All right, you guys know this very well, hopefully. The medulla secretes epi-norepi. So not like the cortex, which is for longer-term processes, longer-term periods of stress. Adrenal medulla is like quick, fast, in a hurry. Boom. Lightning fast stressors causes to happen. So now we're talking the very middle, little midget portion, epi and norepi. Which is why when something goes wrong with that, that's obviously a huge problem for your patient. Because you're just sitting there in your chair and you're feeling like your fight or flight is going on right now. That's a problem, right? We'll talk about this condition. So again, now we're talking about the short-term stress, the box on the left. Short-term stress, completely different pathway than what longer-term stress is what we talked about for the past 2 days. last time I saw you guys, whenever it was. So this is all the crap that happens with that. So increased heart rate, increased blood pressure, right? Decreased blood flow to the belly, right? I don't want to like crap my pants as they're running in the hallway. I don't want to do that. So that's not going to happen. So we become like constipated essentially for a second. Dilation of bronchioles, right? Everything gets opened up. So and increases your metabolic rate, as you can imagine. So yeah, this make sure. So you're not like screaming diarrhea and you're beating yourself going down the hallway. You don't have them. That's good. That's a natural response to this fight or flight. Anxiety kicking up, increased tachycardia, increased blood pressure, and you're going to escape this, whatever freaked you out at the time. So that's what's supposed to happen. Any question on that? I'm just like going crazy. Slow. All right. So these are some of the major signals that are supposed to trigger the catecholamine effect. So the catecholamines means epi and norepi. You guys know this already, but just, you know what catecholamines are. So decreased blood pressure, decreased blood volume, decreased blood glucose. Any one of those things should actually bump up your catecholamine response. That should bump it up, hopefully with short term. So again, if I'm bleeding all over the floor again, chop my leg off, poor guy. That is a normal response, in addition to everything else. Normal response is just happening to trying to save your life with this thing. But again, fortunately, you can't go through this for very long because otherwise you end up in shock, which is also a problem. Severe illness and severe emotional states, that can also kick up in the signal. So this is all normal stuff where catecholamines can be released. So I love this picture. I had it in your, when you were freshman in med history. I like it. So we say this, you're supposed to think about your horses, but I tell you guys to think about zebras because I promise you guys are going to see zebras. I promise you, you're going to see them. Let me know you saw them. So this is not, it's not a horse, it's not a zebra, it's an effing unicorn. So this is what the patient has. So every single pants you're going to have has a question about pheochromocytoma on it. I guarantee it. It's one question. It's very rare. I don't care, but it's a test question. Because if you miss it, it can kill somebody. So what do you guys learn about pheos in pathology? Yeah, what do you learn about them? Like, good. I totally did. Cool. So again, we've got the gist of that. What I'm going to change as far as what Mr. Weber, which he's badass, I love him so much, what he taught you is the lab is different. So I'm going to give you a much easier lab to know for this. So you got to learn this one, that it's in current. I didn't make it up, I promise. So when you get to labs, we'll talk about this. So first we're going to talk a little bit about what the case is. So pheochromocytoma, and we also have paragangliomas. For most of this lecture, I'm going to talk about only a pheochromocytoma, okay? It's a little bit different. So on the exam, it's only going to be a pheo. Only going to be a pheo, okay? But paragangliomas are very important as well. That's basically anything that didn't show up on the adrenal gland within the adrenal medulla. So first about pheochromocytoma arises from the adrenal gland and secretes epi and norepi. No kidding, kind of makes sense. So I'm secreting it, and I didn't earn that. I shouldn't be secreting anything, so that's a problem. Rare, so yeah, of course I'm giving a question on it. Good job. But it's a very important thing because it will absolutely kill your patient. So don't miss it. It doesn't take long to kill the patient either, so it's a very important you got that. So paragangliomas, they basically, you kind of think about, it kind of looks like a system along where your lymph node system is. Don't worry about it. I used to have a picture of it. Don't worry about it. But basically, this is outside the adrenal glands, and the difference is this one only secretes norepi. So before, this is epi-norepi as far as pheochromocytoma. Paragangliomas is only norepi if you care about that. When I give you the quick story, that'll make better sense, but makes sense. So, some women don't actually secrete at all, which is interesting. So then how to go figuring it out? How do you think you would figure that out? Accidentally, exactly. Very much so. Remember, an accident is yours now. You got to figure out what the problem is. All right, so both of them can be lethal, but PHOs are more common than perigyniomas. I'm so sorry, my phone's making noise. That's annoying. I'm so sorry. Oh. Text me. Oh, she goes to college this month. Oh, my heart is breaking in Colorado. Okay, so pheochromocytoma, again, focusing on only this. So these are the key symptoms. So you gotta remember, these are key symptoms. A patient will not present with this without one of the key symptoms. I promise you, they often have a lot of stuff in the bottom part of the list. But hypertension, headache, diaphoresis being spotted all the time, and palpitations. So those are the key symptoms to learn cool box. So anxiety and nervousness or a sense of doom. Literally, patients who present with PHOs, and yes, I've caught PHOs, yay, because I'm weird. But honestly, they always feel like, I feel like I'm going to die. Like, I'm just sitting there and I feel like literally I'm going to die. Like, why do I feel like this? So it's often written off and it's an anxiety attack or something else gives it anxiety. Depression is very, very common in this day and age. This is very, very common. So it's written off a lot. But again, if they have some of these upper symptoms, and then they also have this anxiety, nervousness, sense of doom, listen to your fucking patient. Do it. I just cursed quietly. I didn't say it that loud. All right. So these are some of the other things I have. So nausea, vomiting, abdominal pain. That's kind of a vague one, right? Nobody with nausea, vomiting, abdominal pain has a PHO by any means. But combine it with some of the other features. Weight loss and decreased appetite, right? Weight loss is very common if you have anxiety. Decreased appetite is very common with anxiety. So then sometimes people think, oh, you're losing weight, you're not eating much, you probably just have anxiety. So I'm literally talking to a phase 2 student right now, because he remembered me writing to me about this person who is being worked up for hyperthyroidism, and his blood pressure is through the roof. I'm talking like 210 over like 115, like insane numbers. And they're kicking me out for he's like his anxiety is up through the roof. I'm like, do tell me more, right? And so she's like, I'm working him up for a PHO. I was working with a psychiatrist, literally a person who's been in med school. Sorry. And he's like, he didn't know what metanephrines were, but they were elevated. So I'm like, oh my gosh, he found these zero. So we'll find out if this is actually unicorn. To continue, we'll see. So constipation makes sense, right? Because that one swing that happens, right? You don't want to be, you're running out of the room. You don't want to be pooping your pants. So constipation is a normal side effect of this particular complaint. Okay, any questions on what the key symptoms were and some of the other symptoms? That kind of makes sense, right? My metabolic knob is on overdrive for no reason. Okay. So this is other key symptoms, and this is not stolen from you on your pants as far as when you go to take this. But paroxysms, that's basically if you have, this is episodes that come and go. Come and go. That's a huge thing with this. It's not constant. Thank heavens, right? That person by you dead in like 5 seconds later. But it's not constant, it's paroxysm. So sometimes when you're reading the vignette on the pants or my test, you can notice episodic. Episodic is the same thing as paroxysms. Understand that? So periodic, stuff like that. So these are some of the things that cause this to be, to happen. Not always, but sometimes. So again, exercise is a big one, right? Emotional stress, good luck, eye peppers. Yeah. Surgery, obviously, so surgery can do this, and general anesthesia can do this to you. So again, the surgery can do it, the general anesthesia can do it, so that's a double whammy. Somebody who's at risk. So, and then a lot of them are drugs. So some of you guys know some of those drugs very well. Hopefully not all of them, but caffeine. Caffeine is a big cause, right? Nicotine, hopefully not for you guys, don't be good. Any SSRI, decongestants, makes sense. Related colds or amphetamines, hopefully not, but whatever. Cocaine, IV contrast, that's a huge one. IV contrast can trigger a paroxysm. It can also trigger like the end result, like fatal hypertension and cardiac events. Epi and corticosteroids, right? Epi, that should make sense, right? I'm giving you what you're being too much of, that makes sense. But most people don't give epinephrine IV-wise. So typically paroxysm lasts between 10 and 60 minutes, give or take. That's a guesstimate based on what the patients, how they present. So this is the extreme version of it, and sometimes this is how somebody presents. This would be often in presenting at emergency department. They're just like feeling gonna die. So hypertensive crisis, fatal cardiac arrhythmias triggered by one of these things. So one of the crazy ones is vaginal delivery. So I can't even have a kid naturally without having this, or I can't go to C-section without have this. So again, a pregnant lady is a huge risk if, heaven forbid, she had a FEO. Glucagon injection, why would I give glucagon to somebody? We haven't really talked about it at all, because so exactly, if somebody who's in hypoglycemia, boom, easy thing to do. Good glucagon, for some reason, that triggers them, their fight or flight when it goes buck wild. Needle biopsy of the mass, that's really important too, and talk about some reasons not to needle biopsy the mass until you have them stabilized. I'll show you the way you get them stabilized if you determine they have FEO. So again, hypertension is one of the key signs and symptoms, and a lot of times they go crazy hypertensive, very hypertensive, but even at like a baseline, they're still hypertensive. Even on meds, they're still often hypertensive. They often don't bottom out to be completely normal and then crazy elevated and completely normal. But hypertension is a big one. Facial pallor, monocyanosis, and then flushing. So this is often like, you guys have been learning what Raynaud syndrome is? Yeah, good job. It's like a derm thing, but kind of a ortho thing sometimes. But anyway, that's what Raynaud looks like. It's basically, you're basically epinorrhea, what this does to your body as you're going through the process. So facial pallor, mottle cyanosis, and then when you go normal again, you flush. You flush, it's all red. Tachycardia with or without precordial pain, I can imagine it would hurt. And then this is all the crap that can kill you. Multi-system crisis, it's just going downhill, circling the drain. So I'll show you how to not let the patient circle the drain. All right. Any questions on signs and symptoms? Okay, so especially remaining key signs and symptoms. Okay. All right. So labs, you don't want to forget about the basics. The basic stuff. That kind of helps you with the differential diagnosis, because our FEO is common? No, even though we have them here in PA school. But they're not very common. But free T4 and TSH, what conditions will we thinking if I say free T4 and TSH? Exactly, hyperthyroidism, exactly. CBC, because I check on everybody, right? Checking like why are you, why are you peeing away as far as this. ESR, and honestly, that's running current right now, but CRP is often a better measure of inflammation than ESR, but current still uses ESR, so. And glucose, right, it's often going to be often low. They're often going to be diabetic, they're often going to be low blood sugars, but this helps you with the differential diagnosis. So, but this is the money. So, plasma fractionated free metanephrine, money. That is a simple blood test. That is not a 24-hour urine. So I would just all be in the same shitty music, right? So a simple blood test If that's elevated, boom, then you confirm it with a stupid 24-hour urine, which is a giant pain in the ass. Does that make sense? And this is urine current. It's the easiest way of testing for a FEO. So what that means it gives you free medinefrins and free norepinephrines. If it's normal, stop right there. Do not be like, I'm getting a 24-hour urine. I know it's elevated. No. If it's normal, simple blood test, stop there. It's not a FEO. Think of something else in your differential diagnosis, okay? If it's elevated, you move to the next step, which is once again, 24-hour urine fractionated medinephrins, and also you do creatinine as well as part of the thing. The same thing with the, when you, let's say your dexamethasone pressure stuff is elevated, you confirm with the 24-hour urine-free cortisol, and it comes with creatinine. So again, that's common with every urine test we do. But I want you to remember, this is your first test you want to do. Plasma fractionated free medinephrins, easy test, super easy breezy. I don't know how much it costs, so I don't know TSH, I'm going to say it's $1. I don't know how much this test costs, but it's probably a little bit more expensive. So only order it if you have those signs and symptoms in that patient. Do not order it in everybody. I repeat, do not order it in everybody, including yourselves. Please don't do that. But anyway, so if it's elevated, then you get this 24-hour fractionated medinephrins, and you go from there. Does that make sense? The other thing is I want you to realize, it's best to collect that test as close to the paroxysm as possible. So, this has happened to me several times. So what I do, if I'm ordering this test, I put it in the computer, I give the patient the hours of the lab, like they're open from this time to this time, whatever. I'm like, I'll call the lab and say they're on alert for you. That's most labs that can do that, and I know you're the hour, whatever. I want you to get blood drawn as quickly as you can next to your paroxysm, because otherwise, if you got a number that's like teeny bit elevated, is it a FEO or is it not a FEO? I don't know. So again, the better thing, as close to the event, hopefully not killing them, as possible. Does that make sense? It's a big one. Cool. Any make questions out of the labs? So I realize it's a different lab than what Mr. Rowe said.
Internet says $109.
$100. It's kind of expensive per. What's TSH?
I didn't know.
You should look it up.
Look it up too. It's about the same. It can get rangy.
To a TSH?
It goes from 5 to like 100.
I'm gonna say $5 because that's crazy. I love you looked up. Thank you so much. Anyway, so $109. If your patient worth it, we'll see. But again, the signs and symptoms. They have to have the signs and symptoms to make you order lab. I don't order labs in every patient, right? So you gotta make sure you have the signs and symptoms, and then you order lab appropriately. Okay. So labs first, and then imaging, right? So if my plasma fractionated free medinephrins is elevated, boom. I confirmed it, trust but verify, with the 24-hour medinephrins, right? Confirm that. And then I could do imaging. So they're both elevated, then I could do imaging. So non-contract CT abdomen with thin sections through adrenal glands. Does that make sense? Why is it non-contrast? Exactly. That is something that can cause paroxysms. I can also give you hypertensive crisis and you die. So non-contrast is a good idea. Don't do it. If it's negative, you're not testing this one right here. If negative, then you have to use CT of the entire belly, pelvis, and the chest. The reason why, what do you think I'd be looking for then? Paragangliomas, exactly, the paragangliomas. So again, that's the one that's like in multiple places. Again, you're not testing on that. I just want to focus on the FEO, just that's money. It's going to be, if you're going to find it, you got it right back to me and like, yay, found it. But again, this is why I'm doing this, because again, I would never do this test unless my labs were elevated. My labs have to be elevated, then you do the imaging of non-contrast of the adrenal glands thin sections because the adrenal glands are tiny. All right. Nuclear imaging you can do, especially if you have paraganglioma. Again, you don't have to focus on that, but just there's a different way you could do this as well as far as thinking about paragangliomas. All right, that's positive arrow sign. Good job. Yay! All right. So this is the biggest thing. The labs are very important to learn, and also the treatment is very, very important to learn. A lot of people, honestly, with anxiety, sometimes they're given, for example, propranolol. Because like good for like stage fright, anxiety, stuff like that. People take that. That will absolutely kill your patient. Don't do that. So you've got to remember, they need either an alpha blockade or a calcium channel blockade before you do the beta blockers, if you even need them. But again, often they're tachycardic, makes sense. So alpha blockade, benzene, or amphetamine as a calcium channel blocker. You got to understand, either A or C before B. A or C before B. When I mean A or C, meaning alpha or calcium channel blockers before beta blockers. Because again, if you don't do that, you're going to kill your patient. Don't do it. Because beta blockers, any beta blocker, I can write any beta blocker, will worsen the hypertension because now unexposed alpha constriction lead to beta constriction. That will kill your patient. So again, some people figure this out accidentally. So you can use it after you start the alpha blockade, especially with a tachycardic, or if they have an arrhythmia, because that can happen as well, different arrhythmias. But only after the alpha blocker, you gotta make sure. So A or C before B. Does that make sense? Or does it confuse the crap out of you guys? Do you guys learn anything about that in farm? Do you learn anything about FIOs in farm? I'm gonna show you. Cool. So I've got this one. All right. So surgery is obviously a treatment of choice, right? So basically, it's a lot of people in that little skinny room. So a lot of people are working on this particular case. So again, you can kind of see it like the giant mass thing. Good job. And this is obviously it's cut in half. It's not weird. So again, this giant mass looking bad boy. That's the FIO. Alright, all I want you to do, I just want you to understand, you've got to watch their blood pressure, what it's doing, both pre-op, intraoperatively, because that's, there's ready for something to happen to them, and post-operatively. And I want you to watch their EKG, pre-op, post-op, or intraoperative. So each one of those things. That's a lot to say, but basically, I underlined the 4 to 7 day minimum that you have to have the blood pressure under control and as stable as it can be. Because again, when you're under surgery, oftentimes the blood pressure is going to shoot up a little bit. That's a normal reaction to happen with surgery. So stable as possible. That's all this is. Don't worry about any of this other stuff. So in-op or yes, sorry.
I'm trying to understand the beta blocker thing. Is it because you block the beta to the heart that's going to cause, you're going to kick out more of the alpha?
Yeah.
More of the
Exactly, all vasoconstriction, and that will absolutely kill your patient. They'll go into like renal failure, they're blind, everything happens all at once. It's catastrophic. Yeah. So talking about inoperable or metastatic FIOs, that can actually happen. They sometimes have to have chemo, and then we basically do a targeted radioactive therapy as well to figure out where this is. What I want you to know from this is you do not have the, normally you had to take a biopsy of something and send out to the lab. You'll know whether that's metastatic or not metastatic, or I do lymph node sampling. I know if it's metastatic or not metastatic, or I do imaging, right? The crazy beast with PHEOs, you don't know that. You don't know that based on the pathology of that. So again, you don't need to study this at all, but understand some people have metastatic and they can present years later with the metastases. So it's an interesting thing. That's this thing. So it cannot be determined by histology. Interesting, right? So generally speaking, the larger they are, the much more likely it is to be metastatic. Like all you can do is take it out, or you can see of it, and go from there. This is the hard part. Hypertension might persist in 25% of people even after the surgery. So the patient's always wondering, like, is it still my PHEO? Or is it, am I better, but is still hypertension left? So it's a big thing to think about. It said 5-year survival rate is 44% after surgery, because oftentimes, even if you resected that adrenal gland, there's always a possibility of it going elsewhere. Again, paraganglioma is much more likely to go elsewhere than a PHEO is. Okay. Any questions on PHEOs? All right, so for MENs, so there's 4 of them. All I want you to do is understand, is do one question on this, understand what MEN looks like. I'm going to give you some signs, and you can kind of learn what the signs are. They don't have to have all the signs. You do not have all the signs. But somebody got smarter and realized there's this person who has, for example, basically, oh, yeah, let's say they have bilateral PHEOs, and this person has Hirschsprung's disease, and they also have this condition. They realize there's something called MEN, multiple endocrine neoplasia. That's what they figured out. So again, this is what this is. On the exam also I have MEN2 and then 2A. That used to be, there used to be 3 MENs. They got crazy and figured out there's a 4th one. There's probably more than that out there, but again, just understand how they present. It's going to say, like, you know, whatever, a 27-year-old male presents with X, Y, and Z. Understand which one they have. That's it. That's all I want for you guys. Because otherwise, I would look it up. All right. So again, this is why there's an MEN4. All these things are very common in them. But again, I haven't listed out. So the first section, when I look at the second page, not so much. Will make sense. So this is the stuff that happens, and it doesn't have to be everything happens, but just understand this. So MEN1, most common multiglandular syndrome, so it's kind of cool. Also known as Werner syndrome, so please learn what both means. Pretty please. So hyperparathyroidism, which you're going to talk about in block 2, way back. Block 2, the very last lecture. Hyperparathyroidism. So they're caused by parathyroid adenomas, makes sense. And oftentimes the way we figure this out is doing labs on this person and figure out they have way too much calcium, like way too much. And they're probably going to have symptoms and signs of having way too much calcium, and I'll kind of talk about that in block 2. So these are some of the other things I have. Phalangeal angiofibromas, which is little lumps on the face. Pancreatic, not pancreatic, like carcinoma, not like that. It's more like it's an endocrine tumor, so it's a little bit different. Pituitary adenomas, enteropancreatic tumors, and then adrenal adenomas are hyperplasia. So again, not all of them, but at least some of them. I usually will list at least 3 or 4 of them on your thing, and you're like, I picked it out of lineup. Good job, Gumi. We're thing test run. So if you do care about this, you don't really learn this, but if you care about this, how it works, how it presents. So typically in the 3rd or 4th decade, the signs are very variable depending on, like I said, we often figure this out, that they have the elevated calcium level. Maybe they had, for example, renal stones. That's a huge reason why somebody would have these effects. And then basically remove the adenomas if possible, and then control the high calcium level, because high calcium level can also kill you. So we don't want that either. Right, so learn this, not learn this. This, not that. Good job, good. All right, amen 2. Any questions on that? I'm just speaking through too quickly. So do 2, also known as Sickle syndrome, and then we'll take a break, okay? So these guys, medullary thyroid cancer, 90% of people have that. The interesting with this one is bilateral pheochromocytomas. Bilateral. They're often bilateral, but let's be bilateral. Hyperparathyroidism, again, this one, same as the last one, right? And then 1 and 2 both have hyperparathyroidism. And then Hirschsprung disease. Do you guys learn that in GI?
Yes.
Good job. Exactly, so Hirschsprung disease. So again, these guys undergo genetic testing, again, if they know that they have this. Treatment, prophylactic thyroidectomy. Why would I do that? Why would I take my thyroid? Exactly, 90% get medullary thyroid cancer, which is the third most common type of thyroid cancer. It's often seen in immune syndromes. So a huge thing to think about. So, but you have to screen for the presence of a pheo before you give them surgery to take out their thyroid. Make sense? Because all of the things that make you wrong, all the shit either contrast that put on the table, surgery put on the table, all these terrible things that potentially kill you, can do this if I'm taking my thyroid, because the bilateral pheos are so prevalent in you guys. Then screen for pheo. If it's negative, do the plasma test. If it's negative, boom, move on. You don't have a pheo. If it's positive, take care of the pheo first, and then take care of the thyroid. Make sense? Confusion? Cool. All right. I feel like I lost you guys, but okay. All right. I'll take a 10-minute break. I'll see you soon. On the exam, I have 3, and I also read 2B if you care about that. Some old textbooks still refer to it as 2B. I don't know what 4 goes to, but so they're both on there. So this is how they present. So these are the different. So mucosal and GI neuromas. So basically, again, those are like bumps along the skin, but also going throughout the GI tract. So it looks a lot like how if you've ever seen neurofibromatosis, what that looks like, that's kind of what that looks like. Medullary thyroid cancer, so just like immune 2 had a medullary thyroid cancer. Pheochromocytomas, they're often unilateral if you care about that, whereas immune 2 is bilateral. And then this is the interesting one, scalar abnormalities. He basically has a Marfan-like habitus. So I say Marfan-like, what does that look like?
Tall, long, slender.
I like it. Okay, exactly. So I probably had that. Is a Marfan-like. He wouldn't have Marfan, but a Marfan-like appearance. So again, super tall. That's to present with delayed puberty, and the reason why this is often caught very early, often because of the mucosal lumps and bumps. You're like, this doesn't look normal. So early prophylactic thyroidectomy, often for 8 to 6 months. So again, it's very aggressive. This particular medullary thyroid cancer is very aggressive. I was going to say bless you, but you coughed on your nose instead. Sorry, I want to say something nice. All right. So NMN4, new since 2019. Good job. Yay, go us. So this one has a lot of similar conditions, so parathyroid adenomas, pancreatic neuroendocrine tumors, etc. So in the endocrine pancreas, pituitary adenomas, adrenal tumors, and they're also prone to all of these things, depending on the gender, right? So cervical cancer if you're a female, testicular cancer for male, renal tumors, renal cell carcinomas, etc. So it's kind of interesting. So again, just all I want you to know is if the patient has, I'm going to give you at least 3 or 4 things, they'll get you on the dot. Easy money. It's never been a 100% question. I don't know why. There's only 4 of them. You can do this. There's 1 question on that. All right. Any questions on the MENs?
Yeah.
Hopefully, yes.
Those 4 for MEN4 are the same as MEN1. Is there like a good one?
I would have to tell you that there's I would have to tell you also have testicular cancer. I would have to say cervical cancer. I would have to give you one of those ones because that does very much like MEN1. And again, if you like, sorry, 1 second. If you like this thing, it kind of, if you like charts looking like that, that can make it maybe a little bit easier to understand what they are. But yeah, so MEN1 and MEN4 seem very similar. So again, have to say that they have something else, testicular cancer, adenocarcinoma. Welcome, sorry. All right, did you answer the question? Maybe, cool. All right, so incidentaloma is a word. What is an incidentaloma? What is that? Yes, something you did not intend to find, but now it's yours. Now it's yours. And this is a huge, huge deal. Incidentaloma, let's say I thought this person had, I work in the emergency room, I thought this person had appendicitis, and like I'm in the ER, so CT everything. So I did a CT scan of the belly. The appendix is normal, but I found, for example, in this case, a right adrenal mass. Dun, dun, dun. They follow up with PCM. They punched it off. It's your job as a PCMs, because all of you guys ideally are doing PCMs at least in the beginning of your careers. It's your job to figure out what that is. I've just met this lady recently. Well, I guess I thought about her recently. It's a patient from Eglin Air Force Base, and she had, she basically was worked up for, I forget what the chief complaint was, like she had a cough, right? And so they ended up doing a chest x-ray, and it said it was negative for pneumonia. It's positive, positive for pneumonia. She's an older individual, she used to smoke, and then she quit, so that's always small cell lung cancer, I promise you. Somebody who used to smoke a lot, and then they quit, small cell lung cancer. Anyway, they didn't do any type of follow-up as far as her, looking at her pneumonia, because a lot of times, if you know very well, I think you know from radiology, pneumonia, especially in somebody who's older, once that clears, you absolutely need to do a follow-up chest x-ray on this patient, because you oftentimes will find a lung cancer in the spot of the pneumonia. So right, don't do that. She had some interesting things, but she ended up, she passed away. She had small cell lung cancer, no follow-up, nothing at all. And it was metastatic to her brain. She was a sweet lady. She was a spitfire. Spitfire. So, incidentallomas is we're talking only adrenal gland incidentallomas, but you're responsible for anything you find. 8 to 12 people had adrenal masses. That's a lot of people. That's at least 1 to 2 people in this room. Sorry. I probably say 4% of adrenal masses are diagnosed on routine CTs or MRIs, right? I'm looking for, I think you have uterine fibroids, and I got this other problem, right? So I'm giving you a protocol for what labs you need to do in this patient. Labs, and then of course imaging. So what do I understand? The top 3, if it's metastatic, that sucks. Disease, because that's gonna suck. But the first 3 we're talking about, so cortisol producing. What would be a cortisol producing tumor? Cushing syndrome. Yes, good job. Good job. So pheochromocytoma, we just talked about it, so hope you remember that. And then mineralocorticoid producing. So remember aldosteronoma, right? So again, so not always coming with adrenal mass. So I have tests that you need to do to figure out if you have one of these conditions. Does that make sense? If you found it, It's yours. Own it. Love it. Be sweet to it. And we'll figure out what to do. So, labs, order all of these. Every single lab. Every single lab. The reason why is I'm trying to figure out what. So what's the first one looking for? Pheo, absolutely. That's a pheo test. Good job. So now this one's weird, right? Because it's going backwards, not the initial one. You do a plasma incitated in serum cortisol. If that's abnormal, that's the only reason, then you do the plasma dexamethasone suppression test. So that's the only one that's a little bit weird, but again, it's just simple blood test. Excitation cortisol, good job. And then plasma renin activity and aldosterone. What am I looking for there? Exactly, exactly. Yeah, so hyperaldosteronism. So does that make sense? And it's written in bold letters and underlined? Yeah. Makes sense. Order all of them. Do I only order? I caught this, I do no math, don't know what it is because I got biopsy. And I only order free metanephrines. Is that the right test to do? No, good job. Okay, so understand all these tests. And now this is weird. All right, so then you have to image him. So imaging at 6 and 12 months, if it's non-functional, remind me from back in lesson 1, what does non-functional mean? Not secreting anything, exactly. So if one of these is being secreted, boom, you go down that treatment path for whatever one it is, right? But if I'm not secreting, non-functional, and less than 4 centimeters. So in the vignette, on the exam, I'm going to tell you what size it is. I want you to learn 4 centimeters because that's going to change what you're going to do for it. So believe it or not, if it's greater than 4 centimeters, you've got to do surgery, no matter what. All day long, you have to do that. Even if I'm not secreting anything, you've got to do surgery. So then every 2 or 3 years, the mass does not increase in size, right? So I'm on CT everybody all day long, like my brain. So CT scans is 6 to 12 months, and every 2 years, if it doesn't get bigger. But adrenal mass is greater than 4 centimeters. That's my learn that shit. Should be surgically removed and biopsied, even if it's not secreting a damn thing. Does that make sense? Because remember, the adrenal gland's not that big. I don't know how big it is. This big. Not that big. So again, a 4 centimeter mass, that's a pretty decent size. So again, even if it's not functioning, that's a problem. And then smaller amounts of that sufficient may observe after endocrine testing. Endocrine testing is the labs are talking about doing all of them. Does that make sense how we do this? Again, you owned it. Hopefully you learned this in every ology you're taking as far as you often find something called an incidentoma. If you were looking for it, bet you found it, own it, love it, call it yours, and do what's right. Always labs first, then imaging, and go from there. What's my magic number? 4. Good job. All right, so a lot of this, I cut out a lot of this stuff because honestly, it's really covered in cardiology. But I'm talking endocrine hypertension. We talked about each one of these things before. Each one of these things. So this is just kind of a reminder for like, when would I think about maybe it's something from endocrine cause causing the hypertension, whether it's systolic, whether it's diastolic, both being elevated, either one being the cause. So hyperkalemia without a diuretic prescription, right? Because that could cause, hyperthyroidism can cause you to get hyperkalemic. So for example, hypokalemia without taking anything to give you that, what do you think that could be? What's that? Consonant could be. Good, you mentioned it, really good job. What else? Bilateral adrenal hyperplasia. You often have elevated sodium, but it's okay. What else? If I had my only malfunctioning, only had a low potassium, only thing ever on this thing. Exactly, hyperaldosteronism. The most prevalent cause, more so than bilateral adrenal hyperplasia, Good job. All right. So presentation at early age, new presentation of hypertension in patients older age of 50. And then, of course, higher degree of severity, right? So especially somebody's popping blood pressure is greater than 110, diastolic greater 110, that's like, so we're like the person was talking about the potential unicorn we'll see. So again, this is a big one. Well-controlled hypertension, all of a sudden it became refractory. It's not behaving appropriately. It's not listening to the medicine. Even if they're on one drug, right? Maybe it's just time for another drug, we'll see. But if I bump it up, it's still not doing anything, boom. Think about endocrine being a potential cause. Increased blood pressure, which is paroxysmal. What does that mean? Fetal all day long. Nothing else does that. A fetal. Absence of obesity. I'm not obese either. And obviously, new signs and symptoms of something suggested endocrine disorder. So you got to listen to your patient. Not our patient's fat. So listen to your patient. So we talked about all of these options. So I just the evaluation. So thyroid dysfunction. If you do thyroid dysfunction, TSH, free T4. You want to do, bless you. You want to do T3, go for it. That's also fine. Do a thyroid panel. Good job. But again, you got it, the basics of I think it coming from thyroid, which is a very relevant cause of hypertension. Very relevant cause of hypertension. Which one typically presents with diastolic hypertension first? What's up? Hypothyroidism, exactly. Hyperthyroid is going to be systolic and diastolic. But something kind of cool, diastolic hypertension in hypothyroidism. So again, hyperaldosteronism, what labs are in need? It's a very lab-heavy course. Don't hate me. So serum potassium is going to be low, aldosterone, duh, and then the PRA. All right, so we already know what are you going to do for pheochromocytoma? Plasma fraction and free nephrins. So just lay in the lab. Easy lab. If I think you have Cushing syndrome, objective clinical findings, and then obviously how to go about testing it for that. First thing you need to do, what's the first test you're going to do if I think somebody has Cushing syndrome or Cushing disease? First test you're going to do. It's like very quiet, very sad. Just muscle suppression test. Good job. Okay. It's elevated. The cortisol is elevated. So then what's my confirmatory test for that? Exactly, 2-hour urine cortisol, and then the buzzkill to figure out where it's coming from is ACTH. ACTH, okay. Crickets, I'm kind of worried. Freak me out. All right, so if you're thinking acromegaly, which can cause hypertension, often proceeds even after you surgically treated the poor guy, he still has hypertension. But serum IGF-1, you go from there, and hypercalcemia, that's the only one we've really spoken about, but that's your serum calcium number. That makes sense how we go about figuring this out. All right, so just treat whatever the problem is, right? So again, a lot of your hypertension is essential hypertension. But again, if you see some of those red flags, even one of those red flags, you gotta listen to your patient, especially if they were, previously healthy or previously well controlled, etc. So treat the underlying cause of that. So I made my cool, weird thing. This little chart thing. So you kind of give you an idea of like what happens for each one of those. Some of them are only over secretors. They're not secreting, but just hopefully that's useful for you guys. All right. Any questions on the crap we just spoke about? All right. So quick story. So it's a very valuable quick story. Like I said, it's not very quick. So the biggest thing with this is, I think you guys know where this is going, because I think Mr. Barber told me about that. The lab test is different. This is a long time, well, not that long ago. It's a little while ago when I taught here before the stroke, before I lost my optimist. Just so you know, the lab is different. Just so keep that in mind, okay? So this is a 22-year-old male with palpitations times 4 years, and they're intermittent. Intermittent also being episodic, also meaning paroxysmal. That's all the same words. 114, we used to put this number first, by the way. It used to be the little number with the bigger number, but now I changed it 14-1 PAC, whatever. Those are weird. The student presents with palpitations without tachycardia while sitting in classes in PA school, attributed to stress. The spells lasted from 1 to 10 minutes. He also feels warm with each episode, but denies sweating or pallor. Reports a headache with the symptoms, work on the back side of his head. Spells also occur during exercise. It runs 2 to 3 miles 3 times a week and has to stop exercising and drink water. That's funny. He states his spells seem to occur more frequently over the past couple of years. Now the spells 2 to 3 times a week. So here's how we kind of figured this out. So the patient was recently pretend patient for the FAST exam for PA school. And the PA faculty noted a potential kidney lesion, and the CT scan was pending at the time. Okay, so again, not the right order. We think it may be something we did kidney, with something funky back there, and so we'll get that. And again, he's also enlisted in Air Force. Kind of matters. Not really. Okay. Here's the review systems. I kind of do like the old school, like med history stuff. Fatigue, no kidding. Fever was not recorded, but he feels like he's been flushed. Denies everything else. I put in bold if it's something positive. So coughing, palpitations, constipation, nocturia, meaning peeing at night, headache, and stress. Obviously, no shit. Everything else is negative. So past familial history, hypertension, past surgical history, left tib osteotomy, age 7. Medications, he was taking telmisartan 20 milligrams a day. He was compliant. Multivitamin a day, Claritin every day, mag citrate, PRN. What's mag citrate for? Exactly. Hopefully make you go poo. If you're constipated, you could take that as needed. Allergies, not allergic to anything. Family history, dad had thyroid cancer. Mom's healthy. Social history, married, non-smoker, now, no alcohol use, no drug use, PSU. Blood pressure, is it normal or abnormal? Exactly, and he's on mycarvis at the moment. Everything else is kind of boring. This is mostly stolen from his own notes. I stole them. I borrowed them with his permission. Everything is normal. Followed blood pressure 160/104. The rest of it is boring. Anybody have a time with that? Cool. So, problem list, oodles and noodles of things. Palpitations, elevated blood pressure, fatigue, headache, constipation, labs, lots and lots of them. Followed with PCM after the CAT scan, reported ER if nods, vomiting, increasing pain, dizziness, and stroke symptoms. So, obviously, buzzkill, I told you what it was. Well, most of what it was. So what's in your differential now? Does anything reach you potentially for a few? Cool. You said MEN1, I like it. Reasonable. Exactly. Well, it has feos in it. Okay. So again, is pheochromocytoma in your differential based on this chief complaint? It should be, exactly. Not to be crazy, it should be in your differential. At least a differential. I'm not saying that's a diagnosis, but in a differential. So, he's oodles of labs. Oodles of noodles. Again, the labs are not, they're not always the same with what I would order. But these are his actual labs. Doing good on testosterone. Good job. That's all pretty boring. Any questions, concerns? Moving on. That's not normal. So he had the 24-hour urine metanephrine creatinine. So understand that is not the go-to. As you guys know, the plasma epinephrine is the go-to test for you guys initially. But he had the 24-hour urine epinephrines. So, is it normal? How is it? Clearly not. No, not normal. So, normal epinephrine. Go here. So, 9837, is that a little elevated? Yeah, that's crazy elevated, right? So, now less than 297. And then on this one, normal epi is less than 20. And normal no epi is less than 80. So that's crazy. So what's in your differential now? Yeah, exactly. Yeah. So he also had some other testing done, endocrine testing, which I'm very proud this is all done, and that's very important. What else do you know that's elevated on this in this example? Calcitonin. Is there anything that said they sometimes make the calcitonin go up? What's that? Thyroid cancer, specifically which one? Medullary thyroid cancer. Oh, so we're getting closer. So, this is that's the IPAP guy and teach him. That's the IPAP guy. Keep in mind, he wasn't seeing a theo. Why was I saying that? What's the top of it? What's the study? With contrast. With fucking contrast. That could kill him. Thankfully he didn't die. He's good to go. With contrast. So don't do that. But leave the impression, because this is what a typical radiology report looks like. So understand, it wasn't just a theo. Look at, they were saying, oh, it could be something metastatic, it could be melanoma, it could be testicular cancer. It was saying like, oh no, shit. That's a typical report of like, please correlate clinically. That's the story of my life for radiology. I love them so much. But that was, please correlate clinic, laboratory values for virginal evaluation, consider surgical oncology for further workup. No shit. So that was discussed. But these are his images. Notice anything wrong? That's probably just that view of it. I don't think you guys can see my mouse. Can you see my mouse? Okay, good job. Yeah, so this bad boy and this bad boy. That's greater than 7 centimeters. This bad boy. And this bad boy. That's the best slices. I have all of his CTs, but that's the best pictures I got because I'm cool like that. You see? So he also had a PET scan. No shit. So he had not one, but 2 bilateral VOs. So when else do I talk about bilateral VOs? Tested. Yeah, good job. Yeah, and 2. At the time he is 2. So bilateral VOs, going back a while. Thankfully, it was not paragangliomas. So he had MEM2. He called it 2A back then. That's what it was called. Now it's called MEM2. Bilateral pheochromocytoma. He is now status post-adrenalectomy. Both adrenal glands gone. So he's at Addison's for the rest of his fucking life. Exactly. Cortical adrenal insufficiency post-procedural. No kidding, you can imagine, because I'm taking steroids. I have to take them every day the rest of his effing life. Secondary hypertension to endocrine disorders. And of course, medullary thyroid carcinoma. Guess what? Dad also had medullary thyroid cancer. Didn't think to pass it on that he had that. Interesting. Follow up to 4 weeks in endo. So, I'm not kidding you. This kid had his surgery, the initial, he took out both of his adrenal glands, here, and IPAP. He's a junior then. Then they took out his thyroid. He had it completely removed. So now he's on cortisol for the rest of his life. And then he's on What medicine do I give you if I took out all of your thyroid? Oh my God, you're killing us all. I'm killing you. No, exactly. Levothyroxine, exactly. Levothyroxine versus he was still taking tests. He didn't fail a single test. Never. He's like, I'm telling you, this guy's a badass. And he got through there. He didn't have to recycle. He didn't do anything. He's take out my adrenal glands, I would quit. Take out my thyroid, I would also quit. He graduated phase 1. So, like I said, this is my don't be sweet, but if you have a cold, I am not as sorry for you as I used to be. I love you guys, but no. So sadly, this young man was MEB'd from the Air Force. I do believe the Army kept him, but what do I know? But he was MEB'd from the Air Force after he graduated from phase 1. So he graduated from phase 1 where I was going through. Then he MEB'd him, so he could not go to phase 2, even though we just opened inside of BMC, which kind of irritates me. Because he MEB takes so effing long, he could have graduated from phase 2, but whatever. More shockingly, he had originally had an EPTS diagnosis. You may know what EPTS is? It existed prior to service. Bullshit, the guy had no clue he had MEM2 or bilateral FEOs or medullary thyroid cancer. He had no fucking clue about that. He had none of that stuff. So we fought that one hard. We did all the appeals. I sent a letter to the Air Force Surgeon General on his behalf. He finally revoked the EPTS and awarded a medical retirement. Because after you hit 8 years, nothing counts as EPTS. But if he was at 7 years, and so you're like, oh, EPTS, he was going to leave with no adrenal glands, no thyroid, wonderful medical insurance. Oh, killing us all. So his awarded medical retirement, that really helped him a lot. Also wrote him a letter so he could do his clinicals for phase 2 to go to UNMC, because they have no concerns being missing all these pieces. He was very stable and good to go. Which just really sucks because he had to go up there, and he was originally supposed to go to Nellis, I think, but whatever, so that changed. Yeah, so he just clinicals. Now he's a PA working one of the places near Nellis Air Force Base in Nevada, which is really funny because I said the guy who for acromegaly also now practices in as an EMT near Nellis. It's funny, Las Vegas. His sons are also negative for MEM2 and genetic testing, which is awesome sauce. They're older than that, but that's cute. Badass PA. Alright. Any questions on that? Remember, quick stories, I think it's really cool. It's very, my heart got into that very much. But again, the labs are wrong, so don't remember the labs. And for questions, don't do a contrast CT. Don't do that, please. All right. Do you have time to give a quick story, or do you want to wait until whenever I see you guys again? Okay, good.
No.
Oh, you do? Oh, I didn't know that. Oh, I thought you were done with me. I'll just do this. Okay. I thought you were done after this. I'm so sorry. All right, cool. Clickor. Yeah. All right. That's your patient. So, 37-year-old female complaining of recurrent episodes of palpitations, headache, and excessive sweating, tests 5 months. Past medical usage, nothing. Family usage is adopted, no tobacco or alcohol use. Blood pressure is really wonky. She's tachycardic. Everything's boring. Recent CBC, TSH, and CMP are all within normal limits. So what is her problem list? Remember, problem list, not the diagnosis, problem list. We're going to do this for the lab too, that get hypertension. What else? Hyperhidrosis, very good, technical term. What's up? Sweating, yeah, palpitations. Tachycardia, okay. All right. Good job. So again, the problem list, what I'm really doing with the problem list, I'm really helping you understand where you kind of fit this. Does this fit this condition? Does it fit this condition? Does it fit this condition? That helps you to eliminate things if it does not fit them. So the signs and symptoms are really important so that we kind of understand. I'm going to order like every lab on earth. I can't do that. I'm going to order the appropriate labs for this person if they need labs, okay? So, oh shit. Post-kill. We're supposed to say labs first. No. All right, so what lab do you do? Yeah, well, she had a TSH. It was normal. Yeah, so plasma fraction, pre-reference, and norepinephrine. Is it elevated or is it normal? It's elevated. So what do you do to confirm it? Exactly, 200 European reference. Can't speak words. All right, jeez, please, man. So, 200 urine, free reference, and creatinine. Normally is really high. I didn't give her normal ranges. That's my fault. So it's elevated, right? So, what would you do next for this patient? Non-contrast, also CT of adrenal glands, thin little slices. Good job. All right, I got that. Good job. So non-contrast, good job. Adrenals, thin slices, 3 centimeter right adrenal mass. Good job. So you got a few. Right. Kick them off to endo, and surgery obviously because that's need to come out. Medicated for further workup. So what medications, if I started her on a medication, which one of two would I choose? A or C, exactly. I like it, exactly. Exactly. So amphetamine or phenoxyphenamine. All right. All right. So, a 16-year-old female who is brought into an MBA and is brought to the ER. Past medical history of hypertension. Meds, taken hydrochlorothiazide once a day. No significant history reported. Doesn't smoke or drink, which is really boring. Blood pressure is boring. Physical exam is boring. Those labs are also normal. Abdominal CT scan, of course, because of the ER, they CT everything. 2 centimeter right adrenal mass. So, you now have a 2 centimeter right adrenal mass. Now it's yours. Follow with PCM. It's yours. Not a problem. You didn't die. Your problem. So now what do you want to do? Labs. Which ones? Yes, all three. But what are they? So the plasma freedom and efference. Good job. And this is kind of funky. ACH and cortisol. That's kind of wacky, but yes, exactly. And then what's the last one? Exactly, renin and aldosterone. Yay, my progress, yay. All right, so everything's normal. Good job. You saved your life. Now, do you want to do anything else? What's that? 2 centimeters. So what? Awesome. 6 to 12 months. Awesome sauce. Exactly. 6 to 12 months. CT scans at 6 to 12 months, and then over 2 to 3 years, as long as it's not growing in size. Make sense? So 4 centimeters, I need to know the number. This guy, he's cool. I like the picture. Needs routine follow-up for hypertension. He feels okay, except he still gets a headache when BP is elevated. Hypertensive for a couple years, doesn't smoke or drink. He's only Cinepil 20, atenolol 25 daily for hypertension. He's compliant. Dad also has hypertension. Blood pressure's a little wacky. Home records reflect similar, but it was controlled previously. Just happening. Pulse is boring, blood pressure is boring. So fundus, because you're awesome like that, you can actually look at the fundus to back it up, I promise. AV nicking bilaterally. AV nicking, I promise, and not just a script thing. Regular reading rhythm without murmurs, gallops, or lung rubs. Abdominal, no breweries. So now what do you want to do for this guy?
This one needs to go straight to the ER because it's hypertensive emergency with organ damage. Not a problem.
Not a problem. What are some other possibilities? This is what AP thinking looks like. It's a real thing. I've had ophthalmology in your sophomore semester, forgot about that. It used to be senior semester, which makes no sense. But that's what it looks like. All right, preliminary labs, good job. So basic tip, we figured out what the BP caused. So again, this is abnormalities. The only thing this person has is he has hypokalemia. Hypokalemia. All right, so what is his problem list though? Hypertension, yeah. Hypokalemia. Exactly, headaches, exactly. All right, and AB Nikki, I don't need to know about that. All right, so now what do you want to do for this person? What are you thinking about as far as the biggest thing in your differential list right now? Yeah, hyperaldosteronism, exactly. You got to think about that. Don't forget that. Good job. So aldosterone is elevated, the PRA is low. So that matches what this looks like. So PRA is low, aldosterone is elevated because it's no shit. Hyperaldosteronism, good job. That's a problem. So how do you, what do you do next? Exactly. Why do you do CT? Government labs are good at that, right? What's that? Potentially, yeah. What if this guy has bilateral adrenal hyperplasia causing migraine? So again, you gotta make sure labs first and then imaging. So internal medicine, endocrine referral, obviously internal medicine is way more prevalent than endocrine, but you're not testing them at all, but just, it's a lot easier to do. So you would do a CAT scan on this person, right? Because then I'm trying to say, you only have your aldosterone elevated, or you also have bilateral adrenal hyperplasia, or continuum, anything like that. But good job. I should have added that, my bad. Any questions or concerns?